Hello class, and welcome to your third and final podcast for fluid and electrolyte imbalances. This is Mrs. Hesson again, and we will be going over the different types of fluid and electrolyte imbalances that affect our clients and how we manage the care of them. Once again, remember that this podcast is in addition to the information you get from your book, so please don't find it as the primary resource, but it should be helpful to you to help to solidify and put together the information on electrolyte imbalances. The first electrolyte we're going to talk about is sodium. Very important to know that sodium is the most abundant electrolyte in your extracellular fluid. Normal ranges are 135 to 145. It has a major role in controlling your body's water. Remember, the sodium and water follow each other. It functions in creating electrochemical state needed for muscle contraction, so that sodium is essential in order for muscles to contract. It is regulated by thirst, the ADH, if we remember where that was secreted from, and then renin, angiotensin, and the aldosterone system. A loss or gain of sodium is accompanied by a loss or gain of water. Once again, remembering the basic chemistry of sodium and water and how they follow each other. So the first disorder we're going to look at is hyponatremia, or not enough sodium. Too little sodium. Plasma concentrations are related to the total body sodium and the total body water. Pathophysiologically, there are two reasons why this can happen. First reason is because there is salt loss that is greater than water loss. That situation, if you can think about it, would be related to losing fluids or losing salt from our body. So those circumstances would be vomiting, diarrhea, a fistula, sweating, diuretics, and aldosterone deficiency. That would be due to an adrenal insufficiency. The second cause is excessive water relative to the total sodium. And this would be what we call a dilutional hyponatremia. It's associated with an increase in the water. Too much water too fast. Situations called water intoxication. Dilutes the patient's serum sodium level by an increase in ratio of water to sodium. It increases extracellular fluid volume with normal or elevated total body sodium. High-risk patients are patients with ascites or who have cirrhosis of the liver, those patients with syndrome of inappropriate ADH hormone secretion, a patient with hyperglycemia, and anyone who has excessive intake of water. So electrolyte poor parental fluids or tap water enemas. Irrigations of NG tubes with tap water instead of normal saline. And once again, you can always have those radio competitions or those competitions of who can drink the most water as fast as they can. And there has actually been reported deaths due to them. There's a picture in your book that helps to explain hyponatremia. It's on page 67. It also explains hypernatremia, but we're not there yet. So if you're going to, if you can go to that page, page 67, know that in hyponatremia, the water, the cells swell as water is pulled from the extracellular fluid. So there's a low solute to water ratio. So the cells are swelling up, if you can think of it that way. If you think of it that way, it will help you to understand the clinical manifestations that occur. Once again, they depend on the cause, magnitude, and speed. The clinical manifestations of hyponatremia depend on the cause of the hyponatremia, the magnitude, and how fast it happens. True loss of sodium that is associated with fluid volume deficit, what kind of symptoms do you think you would have? If we think of fluid volume deficit, I'm hoping you will remember this. So, poor skin turgor, dry mucous membranes, decreased saliva, orthostatic hypotension, and associated tachycardia, nausea, abdominal cramping, and headache. Dilutional hyponatremia, which is usually associated with fluid volume excess. Again, if you're remembering the signs and symptoms of those, fluid volume excess, we would have edema, crackles in the lungs, ascites, JVD, and neurological changes. And those are related to the osmotic water shift that occurs. So dilute extracellular fluid causes water to shift into the intracellular fluid. So if you think of brain cells, that's when we would have a condition called cerebral edema. The problem is the brain can't expand. The skull is in the way. So these patients who get cerebral edema will get sick, and they will get sick quickly. They'll have an increase in their intracranial pressure. Symptoms of that are altered mental status, headache, lethargy, seizures, progressive decrease in level of consciousness, eventually leading to coma and death. So remember, increase also or signs and symptoms of increased intracranial pressure are also lethargy, confusion, muscle twitching, focal weaknesses, hemiparesis, papilledema, and seizures. Generally, if hyponatremia develops quickly, the outcomes are poorer because the body does not have a chance to adjust, and there's great increase in the fluid in the cells, and the outcome is poor, especially from a cerebral standpoint. So what do we do to manage this situation? Well, guess what? Depends on the cause. You'll probably get sick of hearing that after a while. With true loss of sodium and associated fluid volume deficit, careful PONG and parental administration of sodium. So that means we give sodium, but we don't give it too fast. The IV fluids can include lactated ringers or isotonic normal saline, which would be 0.9%. We slowly increase serum sodium levels. And I can't say slowly enough, because if we go too quickly, then we can cause a resultant hyper situation. And there's a process that occurs in the brain called osmotic demyelination. It occurs when we increase our serum sodium too fast. And the symptoms of that would be flaccid paralysis, dysarthria or slurred, slow, difficult speech, dysphagia, which again is inability to swallow well or a difficulty in swallowing, and quadriparesis. For dilutional hyponatremia, which is associated with fluid volume excess, in this case, we usually treat with fluid restriction. It's much safer for this population than the other. If neurosymptoms do present, you may administer small amounts of hypertonic sodium solution, but it's very dangerous to the patient. Edema and hyponatremia can go together, and sodium water can be restricted then. Have to be really careful with the patient who has hyponatremia and associated fluid volume excess when they have a history of heart failure, because they're not going to be able to adjust to that as well. So if we go on to nursing management, it really follows, again, identifying the patient. We don't mean identifying as in two identifiers, but what we mean is to identify what the patient has, what's the underlying cause. The other thing is you want to identify if the treatments that are being given are improving the outcome for the patient. So we're monitoring I&Os, daily weights. We're looking for any abnormal losses of sodium or gains in water. So for the GI manifestations, remember, if a patient isn't eating or excessive nausea and vomiting and there's abdominal cramping. We're also closely monitoring for those central nervous system changes. If you remember, lethargy, confusion, muscle twitching, seizures. And the neurosymptoms are more common with acute sodium changes, if you remember that. The population that is frequently overlooked for sodium or for hyponatremia is the elderly population and confusion, because they may have some symptoms of confusion or just normal memory changes with aging. They tend to be, the symptoms of confusion are often overlooked in this population. So correction of hyponatremia, encourage increased PO intake of salt if ordered. Be aware that be aware with sodium content in IV fluids, and adequate salt intake should be ensured for all patients taking lithium. Lithium is a medication that we give for bipolar and other mental health conditions, and sodium itself, we want to make sure that the patient gets enough to prevent a condition called lithium toxicity. So that's the summary pretty much of hyponatremia. In hyponatremia, again, look at your patient, look at the situation, and monitor accordingly. The next we're going to go to is hypernatremia, or too much sodium. Obviously, this person has just a wee bit on the French fries, and that's usually not the case. However, hypernatremia is associated with a plasma sodium concentration directly related to total body sodium and total body water. So the sodium level will be greater than 145 milliequivalents per liter. It can occur with a gain of sodium in excess of water, or a loss of water in excess of sodium. And we'll go over those two kinds. Let's talk about what happens, though, and the effect on the cell first. So in a hypernatremic state, the extracellular fluid has a lot of sodium in, so water leaves the cells. So if you think of it, the cells shrink. Remember, in hyponatremia, the cells were expanded. So getting back to the pathophysiology, I'll just go back on that slide really quick. When I said it can occur from a gain of sodium in excess of water or a loss of water in excess of sodium. Let's talk about those two situations. Water loss, the patient loses more water than sodium. You get an increased concentration of sodium outside the cell that causes fluid to exit the cells. And it causes fluid volume deficit both intracellularly and in the extracellular space. Possible causes of sodium excess or sodium excess intake would be someone who consumes too much. Other causes would be hypertonic IV solutions without water supplements, hypertonic feeding preparations, excessive use of sodium bicarb, So if I think of that, I'm thinking of way too many Tums. Watery diarrhea, extreme insensible water loss. So if we remember the burn patient or the patient with an extremely high fever, and someone who has diabetes insipidus, which is a deficiency of ADH from the posterior pituitary. Clinical manifestations of hypernatremia are primarily neurological due to the increased plasma osmolality. As water moves from the intracellular spaces to the extracellular spaces, cellular dehydration occurs. And that means cellular dehydration in the brain as well as all the other cells. So patient symptoms, if you would think about it, thirst, 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 and thirst. Dry, swollen tongue, sticky mucous membranes. That's for your very basic. For your moderate, you're going to see increases in restlessness and weakness, and severe, you'll see disorientation, delusions, hallucinations, and as the cells in the brain shrink, you can actually have a condition called a subarachnoid bleed, where the brain tissue starts to bleed due to the shrinkage in the cell. It can cause permanent brain damage, especially in children. Another symptom of this severe kind will be flushed skin, increased muscle tone and deep tendon reflexes, and increase in urine-specific gravity as the kidneys are attempting to conserve water. Hypernatremia due to dehydration is often overlooked as the primary cause of dehydration of the elderly because the elderly do not always have the same thirst regulations, if you remember that from our fluid balance, and they will oftentimes not communicate their thirst. So that's a very important aspect of your nursing care. The medical management of hypernatremia is to gradually, as I say, gradually decrease the sodium concentration, and that is done through the infusion of hypotonic electrolyte solutions or isotonic non-saline solutions like D5W. Most clinicians believe that hypotonic sodium solution is safer so that you have a decreased risk of a abundance of change that can cause cerebral edema. So it's very important that we're decreasing we're decreasing the serum sodium level on slowly. When we say that, we basically should not reduce the rate more than 0.5 to 1 milliequivalent per liter per hour to allow for sufficient time for the adjustment of diffusion across fluid compartments. Nursing management, identify patients at risk. Again, part of our assessment process. Early identification and treatment improves patient outcomes. Monitor at-risk patients for INO changes, especially looking for abnormal loss of water, sodium intake, excessive use of Alka-Seltzer or other high bicarb things, or low water intake. Medications histories. Monitor the patient for their thirst and elevated body temperature, and remember your aging population. And monitor the central nervous system symptoms. And what are they? If you remember, lethargy, changes in behavior, restlessness, and disorientation. Our primary goal is to prevent hypernatremia. So we offer fluids at regular intervals. We talk with the providers about enteral and parental fluids if needed, and we assess enteral feedings to make sure that there's enough water concentration and a higher osmolality so that we're getting enough water in those situations. So let's summarize the difference between sodium overload or under amount or over amount, meaning hyponatremia, versus hypernatremia. In hyponatremia, the sodium is less than 135 milliequivalents per liter. It is caused by active losses or dilutional hyponatremia. Clinical manifestations vary based on the cause, the magnitude, and the speed of the deficit. We may necessitate fluid restriction or sodium replacement. Nurses must monitor fluid INO, daily body weight, central nervous system changes. For hypernatremia, we're looking at sodium exceeding 145 milliequivalents per liter, caused by gain of sodium in excess of water or by loss of water. Clinical manifestations are primarily neurologic. Treatment is usually hypotonic, electrolyte solutions. Nursing care includes focusing on prevention and close monitoring of fluid INO. Let's go to our next electrolyte imbalance, and that will be potassium. Potassium is the most abundant electrolyte in intracellular fluid. Potassium's normal range is 3.5 to 5 milliequivalents per liter. Its major role is neuromuscular function. Kidneys are an extremely important, or play an extremely important role with potassium, because the kidneys themselves have to be working well in order to maintain potassium. 80% of our potassium is excreted through our kidneys and only 20% through our bowels. Aldosterone can cause increases in the excretion of potassium from kidneys, and kidneys conserve sodium better than they do potassium. So they might excrete potassium even if a deficit occurs. Potassium imbalances are often associated with a variety of things. There's different disease processes, injuries, and medications such as diuretics, laxatives, and antibiotics. And then with special treatments, as in parenteral nutrition and chemotherapy, sodium imbalances can occur as well. So the first disorder we're going to look at is hypokalemia, as in not enough potassium. Why does this occur? Well, there's quite a few reasons. It can be associated with causing increased output. So medications like loop diuretics can cause potassium to be lost. Corticosteroids can also cause potassium to be lost, and specific antibiotics. Excessive diarrhea of greater than 30 to 100 liters, so as many as 30 to 100 milliequivalents per liter can be lost with diarrhea, and with vomiting, 5 to 10 milliequivalents per liter can be lost. Gastric suctioning, recent ileostomy, intestinal drains, and primary adrenal adenomas or secondary situations like cirrhosis, nephrotic syndrome, and heart failure can have problems with hyperaldosteronism, which causes the kidneys to excrete potassium. With a magnesium depletion, it causes the renal system to get rid of potassium as well. So magnesium becomes an issue, and magnesium must be corrected or sodium loss will continue. Those are the conditions that would be related to certain circumstances. Another reason for hypokalemia would be decreased intake. Unwilling and unable to eat patients. So your very sick patients who have had a long time of nausea and vomiting, who are NPO or have anorexia, meaning they're not hungry at all, they just have no desire to eat. You can also get hypovolemia from the actual mental health diagnosis of anorexia nervosa or bulimia. Hypovolemia is associated with alcoholism, fasting diets, and patients who consume more sodium than water. Hypokalemia can also occur in cases where there is metabolic alkalosis because the hydrogen ions move out of the cells to neutralize pH, and potassium moves into the cells to maintain electrical neutrality within the cells. So in the cases of metabolic alkalosis, hypokalemia can occur. Patients with excretion or hyperexcretion or who are receiving IV insulin can also become hyponatremic or hypokalemic because insulin promotes potassium to enter the cells of the skeletal muscles and liver, which causes a low serum potassium level. So based on all those things, what do you think the clinical manifestations are? Pretty much they're widespread problems in neurologic functioning. Severe hypokalemia can cause death, cardiac and respiratory arrest. Hypokalemia is much more common than hyperkalemia due to the number of the illnesses that are associated with it. Signs and symptoms are fatigue, nausea and vomiting, muscle cramps, paresthesia, and arrhythmias. Prolonged hypokalemia, the kidneys are unable to concentrate urine, which causes dilute urine and excessive thirst. There's a decrease in insulin and glucose tolerance, and EKG changes. So if we think about that, there's weakness and overall neuromuscular issues. If we think of an EKG, you start to have a thing called flattened or inverted T waves, and that sometimes can suggest ischemia or lack of blood flow to the areas. You get deep depressed ST segments, and that's this part here becomes depressed. The T wave becomes flattened or inverted, and there's a development of an elevated U wave, which is this. And this is saying that the cardiac muscles are not getting enough potassium. The very interesting thing about hypokalemia is we talked about the normal serum levels being 3.5 to 5, and so hypokalemia would be less than 3.5. What we do know is that symptoms usually do not present until potassium gets to about less than or equal to 3, and then the symptoms occur quickly and the patient can get sick very quickly. So once again, why it's so important to monitor for those patients that are at risk, as well as anyone who has other associated causes. These are more examples of the prominent U wave as well as a flattened T wave. The first example is of a moderate case of hypokalemia, so you're beginning out of the flattened T and the U wave, and you see in extreme hypokalemia, the U wave gets very big. Hypokalemia, I'm sorry. So I thought this little picture was helpful. This is supposed to say a sick Walt. This guy's name is Walt. And it will help you to remember certain things of potassium deficit. The A is for alkalosis. As we said, that's a condition that can occur. So we didn't spell sick right here, but when they came up with this, it did help many people. So sick would help you remember shallow respirations, irritability, and confusion. And then Walt is this guy's name, and he has weakness and fatigue, arrhythmias, lethargy, and a thready pulse. He also has decreased intestinal motility, so nausea and vomiting and ileus. So medical management. If we think about it, potassium losses must be corrected. They should be corrected daily through diet of fruits and vegetables, legumes, whole grains, meat, and milk. And of course, we all know that bananas are a great source of potassium. For medications, PO patients can take medications that do replace their potassium, and that is often the case when they are on long-standing medications that causes decreased potassium. IV potassium is mandatory if the patient has severe hypokalemia. But when we talk about IV administration of potassium, when we talk about the nursing management of it, we must never give potassium IV push. Never, ever, ever IV push or IV bolus. Your book refers to administering 20 milliequivalents per 100 mLs over to 10 to 20 mLs an hour. Most places that I've referenced and evidence-based practice will say that any potassium bolus should be done in an ICU, and the potassium should be diluted in 1,000 milliliter bags. So the nursing management is very much related to the medical management. Identifying patients at risk. I know I sound like a broken record, but if you know your patient is at risk for hypokalemia, monitoring and correcting it before it gets to that 3.0 can seriously prevent any long-term problems. Early identification and treatment, as we talked about, monitor for signs of fatigue, anorexia, muscle weakness, decreased bowel motility, paresthesias and arrhythmias. So remember sick WALT or asic WALT. Encourage PO intakes. Educate your patients about their diet, laxatives, and diuretic use. And again, if you're correcting potassium or hypokalemia, when you're giving IV, it should be in an ICU. And remember, before you can give your patients potassium through an IV, you must make sure that their kidneys are working correctly, because normal urine output must be there in order to prevent the serum potassium from rising dangerously too fast. The other thing is, do not give patients aged blood products if they have impaired renal function, because the serum potassium will increase the longer the blood is stored. And that has to do with the RBC deterioration. So that's hypokalemia. Hyperkalemia is another condition where, of course, you have too much potassium. This is more rare than hypokalemia, but if a person has it, it's extremely dangerous because it can cause cardiac arrest. Pseudo-hyperkalemia, which means a non-existent hyperkalemia, can occur when blood is drawn and there's a hemolysis of the blood sample. So there's breakdown of cells, and it gives a false high potassium. That can occur sometimes if the tourniquet is too tight, or if there's severe thrombocytosis, or drawing blood from an IV line that has potassium in, or aggressive treatment for hypokalemia. So you need to verify the tests. So sometimes there is a pseudo hyperkalemia condition. You just need to make sure if you get a super high potassium that they double check that there wasn't a error in the lab, because you don't want to start treating for it if in fact it's not true. Real hyperkalemia, possible causes are an increased intake. Rare, but there are some sodium replacements that are potassium, and if a person uses too much of that, that would be a problem. The other problem would be if someone's taking too much of a supplement of potassium. Another cause is cell injury. So someone who has a crushing injury, burns, trauma, intravascular hemolysis, or rhabdomyolysis have increased cell trauma. And as the cells are traumatized, potassium is excreted into the intracellular fluid, causing an elevated an elevated serum potassium. Hyperkalemia can also occur due to decreased urine output, as associated with kidney disease, because a major cause of decreased renal excretion of potassium would be that the kidneys don't work. And in acidosis, remember, opposite of alkalosis, potassium moves out of the cells into the extracellular fluid as the hydrogen ion enters the cell to decrease the pH of the extracellular fluid. Clinical manifestations have to do with the myocardium as the primary area. So you will see early changes in an EKG. In this case, you will see peaks. So if it helps you to remember this, in hypokalemia, you see a change in the T wave and U. In hyperkalemia, you see peaked or hyper. In peaked T waves, a depression in the ST segment and a shortened QT. After a while, as things begin to change, you not only get those, but then you get a prolonged PR interval and disappearance of the P wave. That's a huge indicator. We call it the no P, no K, as in don't give them any potassium. Decompensation occurs from a prolonged QRS, and then the patient develops ventricular arrhythmias and cardiac arrest. Skeletal muscles become weak, and you can even have paralysis. There's really little CNS changes here. You do have GI symptoms of nausea, intermittent intestinal colic or cramping, and diarrhea. Diagnosis is made through lab results, EKGs, and often an ABG that reveals metabolic acidosis. Remember those things we're going to be learning about? Would be one of the diagnostic tests. This is showing pictures of the peaked T waves in moderate hyperkalemia. You'll notice that the P wave is flattened in this one. This is severe hyperkalemia. This is not a good sign. No P wave, really wide QRS, really wide function, and that cardiac muscle is getting ready to go into arrhythmia and not do so well. So symptoms, again, we have silly pictures to help remember. Muscle cramps, weakness, and paralysis, drowsiness, decreased blood pressure, EKG changes. So if you can remember EKG and heart, as well as abdominal cramping, and then decreased urine output. So how do we manage hyperkalemia? Well, I know I'm going to say this. Identify our patients who are at risk. For non-acute situations, we can have dietary restrictions and a lot of teaching about prevention. For emergent situations, we have some very specific things that we do. We give some medications called calcium gluconate IV. Note that calcium gluconate is not calcium chloride. There's a big difference. And we give calcium gluconate. Not that it takes necessarily the hyperkalemia away, but it has an effect, and immediately the calcium antagonizes the effect of hyperkalemia on the heart, so that we're protecting the heart first. The next treatment would be regular insulin or hypertonic dextrose, or end hypertonic dextrose, and they cause a temporary shift of potassium into the cells so that it's getting out of the serum. Onset is usually 30 minutes after it's administered, and it lasts several hours. Administration of sodium bicarb, again, it would alkalize the plasma and cause the hydrogen ions to exit the cells to neutralize it, and then potassium can actually go into the cells. The onset is 30 to 60 minutes after administration, and it lasts for a few hours. And then sometimes we will give a loop diuretic, such as Lasix, because it will increase the excretion of water by inhibiting sodium, potassium, and chloride reabsorption in the loop of Henle and distal renal tubules. The book also mentions beta-2 agonists, such as albuterol. They have to be given in really large doses, and they also can cause extreme tachycardia to already stressed heart. So they are not used as often in evidence-based practice. If all of these measures do not work, at times they will do peritoneal or renal dialysis to acutely remove the potassium from the blood. So nursing management, again, identifying the cause. Monitor patients at risk for muscle weaknesses, arrhythmias, paresthesia, and GI symptoms. Avoid false reporting of hyperkalemia. And prevention is the key. Avoid sodium-rich foods. Don't tell them what foods they can have. Just tell them to avoid certain ones. And give them cautions for the salt substitutes that have a large amount of potassium milliequivalents. So in the salt substitute, a teaspoon of salt actually equals 40 to 60 milliequivalents of potassium. And with potassium-conserving diuretics, they shouldn't be used if a person has a renal dysfunction. And we talked about correction of the hyperkalemia and the signs and symptoms to watch for. Always be aware of premixed bags that have potassium in them. Make sure that it's the right amount. Monitor the meds and monitor for EKG changes. So again, to summarize our hypo and hyperkalemia. Hypokalemia is a potassium of less than 3.5 milliequivalents from active losses of potassium or insufficient intake. And remember, symptoms usually start around 3.0 milliequivalents per liter, and the patient can rapidly decline from there. It affects cardiac, respiratory, and muscular areas, so those are the manifestations. Treatment is with oral or IV replacement, and remember, IV replacement can never be IV push and should be given if it's being given for that reason in an ICU environment. Nursing treatment should focus on assessment of cardiac and motor signs and symptoms. For hyperkalemia, we're talking about potassium levels greater than 3.5, resulting from either increased intake, medication changes or effects, musculoskeletal injuries, or decrease in renal excretion of potassium. Its most significant areas that it affects are cardiac and GI. Treatment involves potassium restrictions and or medicines like we mentioned, calcium gluconate, insulin, bicarb, and loop diuretics. And the nurse must constantly observe for muscle weaknesses and changes in the cardiac. Remember, elevated T wave with this area. So the question is, the nurse suspects that a patient who is receiving NG suction has hypokalemia. What manifestations would the nurse expect the patient to exhibit? So what do you think? Hopefully you said EKG changes. Remember, we have a change in the EKG to the T wave and the U wave with hypokalemia. We wouldn't have increased bowel motility because that occurs with the other. We certainly wouldn't have increased muscle strength, and agitation would not be a symptom. So for the other electrolyte imbalances, we're going to go through the major differences of them. Sodium, potassium are the most common that you will see. One of the other ones would be electrolyte imbalances with calcium. Calcium plays a major role in transmitting nerve impulses and activating enzymes. So if you think of calcium, think of nerves and muscles. With hypocalcemia, we're talking about calcium levels less than 8.5 milligrams per dilution. It's usually from inadequate intake, increased loss, or malabsorption or increased binding of calcium with certain medical conditions. It results in a condition called tetany. And tetany is muscle spasm. It is usually diagnosed best through a assessment called Trousseau's sign. And Trousseau's sign if you look in your book, it reminds you of how you do that with the blood pressure cuff, and you'll definitely see the hand-finger spasms occur. With hypocalcemia, you'll also watch for arrhythmias, ST and EKG changes. There'll be an increase in bowel sounds and diarrhea. Again, tetany or twitching of muscles would cause that. There's another symptom called Chef's sign, which is facial twitching. You'll also get hypotension and hyperactive deep tendon reflexness. So tetany would be any kind of spasming of muscles, and if that helps you to remember that, with the diarrhea as well as the facial twitching, the hand finger spasms with Trousseau's sign, and deep tendon reflex would be increased. The nursing care goals for hypokalemia are basically seizure precautions, administering calcium supplements. Food, if it's not severe, you would be encouraging foods high in calcium, and emergency equipment to stand by in case you have hypocalcemia. It requires IV administration of calcium. For hypercalcemia, you've got calcium levels greater than 10.5. It usually is resulting from malignancy or hyperparathyroidism. Results that you will see are weaknesses and cardiovascular effects. And the treatment is diuresis and management of the underlying causes. The next electrolyte imbalance we're going to go over is hypomagnesemia. Don't say that too fast. Hypomagnesemia can occur when potassium levels, remember that relationship we talked about, are less than 3.5. And from the loss of potassium, there is we could have an insufficient intake of magnesium. Symptoms: cardiac, respiratory, and muscular manifestations. Treatment would be oral or IV replacement of magnesium, and nursing treatment focuses on assessment of cardiac and motor signs. For hypermagnesemia, again, we're looking at that hyperkalemia. And these have a direct relationship. So when potassium is high, you will have high magnesium as well. So it could result from that high potassium level. It could be a result from increased intake or medication effects. Sometimes magnesium levels will increase due to musculoskeletal injury or decreased renal excretion of potassium. So again, the two are directly correlated. Significant symptoms, again, are cardiac and GI, and the treatment involves potassium restriction and or medications, and the nurse would be observing for those signs. So those two go together very closely. Another electrolyte imbalance that can occur, and again, these are not quite as common as the first two we went over, hypophosphatemia. Normal serum phosphorus levels are 2.5 to 4.5 milligrams per dilution. It is necessary for multiple physiological processes. Hypophosphatemia can result from nutritional supplements, as in too many other nutrients in it and not enough phosphate. It results in neurological and muscular symptoms, which are treated with phosphorus supplementation. For hyperphosphatemia, it's usually a result of renal failure, and it's pretty much asymptomatic. If you have it, you treat the underlying causes. So not that these electrolytes are not important, but most of them are associated with other systems, and that's why we're going over it this way. The last one we're going to go over is chloride or hypochloremia. Hypochloremia rarely occurs. It rarely occurs in the absence, should I say, more of other abnormalities. So signs and symptoms are usually associated with hyponatremia, hypokalemia, and metabolic alkalosis. So these symptoms go along with those other symptoms. And really the treatment is to treat the underlying causes. Normal serum chloride levels are 97 to 107. And again, we're going to be treating the underlying causes. For hyperchloremia, it's usually related to, hypernatremia, a bicarb loss, and metabolic acidosis. So again, the treatment needs to focus on the restoring of electrolytes and the restoring of fluids and getting an acid-base balance. So here's another question. The nurse is caring for a patient who is in renal failure. During a shift assessment, the patient complains of tingling in her lips and fingers whenever anyone takes her blood pressure. She claims that she gets a spasm in her wrist and hand and that it is very painful. What would the nurse suspect? I hope you answered hypocalcemia. That is a classic sign of tetany that occurs with hypocalcemia. And remember, with hypocalcemia, you can also have hypomagnesemia, which would cause some tingling in the associated symptoms. The other areas are really just distractor questions. The final part of this podcast will be going over parental IV fluids, and I really want you to refer to your book to go over the different kinds of IV fluids. This is really a review, but the three different kinds are isotonic, hypotonic, and hypertonic. Isotonic solutions are those where the total osmolality is close to the extracellular fluid. RBCs will not shrink or swell when you give an isotonic fluid, and they expand extracellular fluid, but 1 liter only expands the plasma by 0.25 liters. Examples of isotonic are D5W, 0.9% normal saline, and lactated ringers. Hypotonic solutions, the purpose is to replace the cellular fluid. So they replace free water for excretion of body waste. They are used for the treatment of hypernatremia and other hyperosmolar conditions. A common example is 0.45% sodium chloride. Excessive infusion of these can lead to intravascular fluid depletion, and fluid shifts from the extracellular fluid to the intracellular fluid. And if we think about that back to our sodium cells, if we had an increase in the intracellular fluid, that could result in cerebral edema and damage. And we want to monitor patients for changes in blood pressure for that. The final kind of solution is hypertonic. And a hypertonic solution has more colloids in it than solute. Examples are D5 normal saline, D5LR, D50, and the 3 and 5% sodium chlorides. These hypertonic solutions would be difficult to give IV push, especially if we're talking like the D50. For the saline solutions, the 3 and 5% sodium chloride solutions, they draw water from the intracellular fluid to the extracellular fluid, so they cause the cells to shrink. So if they're given too quickly, again, we're going to have that other issue. We're going to have circulatory overload, and we're going to have intracellular shrinkage, so you can have those CNS symptoms again. Other IV solutions, just to know, are TPN, or total parental nutrition, blood products, and medications. I recognize this was the longest of the podcasts, and I appreciate your attention on this. I hope this supplements your learning and helps you to better understand this. In class, we will be using this knowledge to be able to put this theory to practice. So looking at different patient situations and deciding what they have and how we would treat them. So thank you again.